So we've been talking to lots of different people involved in the healthcare system, patients, analysts, different doctors, and so forth. Today I'm excited to talk to Dr. Piccinin, who is based in the Hamilton area. Thanks for your time today, Doctor.
You're very welcome.
Now, you had a very interesting letter to the editor in the National Post recently, and we'll get to that in a moment because I thought you raised some interesting points. But first, I want to just ask if you could tell us a little bit about your background as a doctor in healthcare.
Sure. I have an undergraduate degree from the University of Toronto and a master's degree in physical anthropology from McMaster University, and then a medical degree from McMaster University. And I did 2 years in the Royal College program in community medicine and public health. So I have kind of a diverse background, a bit of epidemiology, and I've worked in a lot of different settings, nursing homes, assisting in the OR, and just basically running my own clinic for the last 30 years.
So you certainly draw a lot of experience over the years, and you've worked in different aspects. So I'm excited to hear what you have to say. Now, you made some comments about waiting lists in your letter to the editor. What's been your experience when it comes to patients and the waiting lists that they face in Canada's healthcare system? And first, I'll just ask you about sort of like before COVID hit, because obviously we're in a unique situation.
Mm-hmm.
But what was it like before COVID?
Before COVID, I think, there was unacceptable waits for certain things, unacceptable wait times for joint replacement surgery. Typically knee and hip get the most attention. And so, you're looking on an average, I've got somebody that I do an x-ray and see that they've got a really severely arthritic hip. It would be somewhere in the neighborhood of 6 months for them to get their initial consult with the orthopedic surgeon. And then if the orthopedic surgeon said, yes, I think this probably needs a replacement, they would be looking at possibly 1 to 2 years wait before they got their actual surgery. So that's pre-COVID. Now, all the surgeries that should have taken place have now that got canceled. So we've now got that backlog to deal with. So people will wait even longer.
That's pretty incredible, because if they're looking at 6 months to see the specialist and then potentially upwards of 2 years, that's a 2.5-year wait.
Yep.
For someone before they get that operation, and in the meantime they're probably on painkillers or some kind of other medication, aren't they?
Mm-hmm. So there's controlling their pain. There is an issue because anti-inflammatories, we know generally by and large don't work, for really, really chronic joint pain. And you can get minimal relief maybe with some of the COX-2 inhibitors like Celebrex, Mobicox. But then you've got to consider, things like, the side effects of that, and also possible other drug interactions, and also GI problems like GI bleeds. Although, they're much, much better than the traditional NSAIDs. There are much lower complications with that, but still there are complications. And then, you try to resist. I don't want to prescribe the narcotics. I don't want to get on the Tylenol 3s and the Percocets and so on. But, inevitably they'll come in and say, well, I had some T3s left over from my dental surgery, or my kid had them, or my wife had them, and I took a couple and they worked. And then you're kind of like, what are you going to do then? Say, well, too bad, buddy. You're going to have to live, hobble around and live with this pain for another 1.5 years until you get your hip done. Or you give them medication. And then the problem is, it starts off, they take 1 or 2 a week, then it's 4 a day, then it's 8 a day, in order to just keep them going to work and functioning. And so then, eventually they get their surgery done. And now I've got a problem trying to get them off. They're trying to wean them down off the narcotic. It's just a hornet's nest.
Yeah. Well, it sounds like it's tough to be dealing with that all the time as a doctor. We've talked to patients who obviously come at it from the other side, and they're concerned about what it's doing to their bodies and the addiction element and so forth. So it tough to imagine. Now, are there any particular stories relating to waiting lists? We've done a lot of research on waiting lists. I want to tap into your insight there. Are there any particular patient stories that stand out that you've been involved in as a physician, where you're trying to get a patient to get some type of procedure and they're facing some kind of long period of time before they can actually receive that procedure or visit the specialist. Are there any stories that stand out in your mind?
Well, yeah, I mean, are you talking specifically about joint replacement surgery or
Just in the
any surgery
system,
or just any referral?
yeah, anywhere in
Like
the system.
anywhere in the system. Well, I think we've chatted briefly about this already, but I think that the joint replacement surgery is probably the worst length of time, the worst wait. But I
Mhm.
think that the more serious outcomes are people who are waiting for psychiatric care,
Mm.
and also there's been some pretty bad outcomes. People waiting for dermatology.
Mm.
People that have got serious skin issues, squamous cell carcinomas. Basal cells are not that serious. They can wait unless it's involving a mucous membrane, in which case it is a serious problem. But the melanomas, that's something that needs to be seen in a very timely manner, and it isn't always the case. So.
Mhm.
But as far as joint replacement surgery goes, my experience is Canadians are very complacent. We just, and I wasn't until somebody pointed it out that I started noticing, yeah, we do apologize all the time for a lot of things. Like when someone smacks into me and I go, oh, sorry. I'm like, why am I sorry? I didn't bang into anybody. So, I've started to sort of try to be a more mindful, more woke about, the situation and how it affects people and how complacent they are. And, there's a little bit of grumbling. You say, well, we sent off the referral to 3 different orthopedic surgeons, and it's going to be, we're looking at somewhere in the neighborhood of a year. And they're like, really? Oh, I guess that's okay. No, it's not okay.
Yeah.
Call your MP. Make a fuss. Like, it's not okay. They don't just settle for the status quo. Like, get noisy. Get out there and say this is not acceptable. Because until we do that, right? Until people start saying this is not acceptable, we're
Yeah.
not going to make change, and we're not going to have the ability to access private healthcare.
I'm glad you raised that. When we were working on a previous project related to healthcare, I talked to someone from another country and they watched one of our videos and we were chatting about it. And the individual's reaction was, I can't believe this patient had to wait a year. And that was this individual's just honest reaction. They're not following
Yeah.
healthcare debate in Canada.
Yeah.
And to me, I just thought, wait a sec. I think we are maybe a little bit too comfortable with what I think is a very bad medical situation. Not that the healthcare system doesn't do some things right, but when it comes to these
Yeah.
waiting lists,
Yeah.
we talked about the problems that it causes for patients. Health-wise, there's a lack of mobility. We're taking away their life. And so often that's what we hear from patients when they get the
Right.
surgery. I got my life back. But it just seems like in Canada, we've almost gotten to
Yeah.
this point where people
Yeah.
seem to think a year is normal to wait for knee surgery or hip surgery or
Yeah.
whatever.
Right. And then you look at it's unbelievable that you go to the States and I've got patients who have been snowbirds who have been on vacationing, well, in the past, not anymore, in the Florida, for example, and whatever, get in a car accident, or the guy falls and does something and goes into the hospital. And I got my MRI within a half an hour. I got scoped that same day. The orthopedic surgeon came in off the golf course and boom. I mean, there's competition. They want your business. They are going to bend over backwards to try and make sure that you're a happy camper when you leave that hospital.
Mm-hmm.
I mean, the doctor called the next day, just checking in on you, Bob, make sure your knee's okay. I'm like, who does that? Like, it's incredible, right? But that's the way it is. And, when you're looking at that kind of a system where the person, the payer, the person who's got the dollars has the power. But here, the person that has the dollars is the government. And so, and with the tremendous amount of waste, there's so much money that is getting wasted that could get poured back into the healthcare system that is not happening. And so what we're seeing is just a constant draining and a deficit. And I don't know what's going to happen as my group ages. I mean, I'm 63, and I'm heading into I'm not going to be doing this for that many more years, hopefully. And so, I look at it and I go, great, I'm great. I have to be part of that cohort that's going to be, cleaning their own bedpans in the nursing home. Like there's just no resources left. It's like, people just keep grabbing and saying, well, it doesn't matter. Like, as long as I get mine, I don't care about what's left for the guy behind me. But, we have to start thinking along those lines. There's a huge cohort of people that are aging, and we need tons and tons of resources. We need to be very efficient about how we spend money and what we spend it on. And I can cite many examples of wasted programs over and over and over and over and over. But
I want to come back to that point about Canada's aging population in a moment, but I want to go back to what you touched upon with people going to other countries. We did some research. We got some data from Statistics Canada that showed that Canadian patients made on the low end estimate was over 200,000 trips abroad in 2017, specifically for healthcare or medical reasons. And what has been your experience as a family physician? How often do you hear from your patients that they've dipped across the border to Buffalo or somewhere else for procedures?
An MRI? Yeah. I mean, I'm in Ancaster, which is kind of a little enclave of Hamilton, and it's a fairly affluent area, and so I do have a number of patients that have got the resources. And I can recall, maybe 20 or so years ago, like when MRIs first came out, it was like, are you kidding me? Like, if you got the golden MRI ticket, you were so lucky. I'm 40 minutes to Niagara, to Buffalo. Like, I send people across the border to Lockport, and $200 US later, they come home with their MRI in hand and then go off to the surgeon. How did you get this? I bought it, Buffalo. It's like, it's super, super easy. I've been sending people across the border for 20 years to go and get there. Now, this is the funny thing, and I don't quite know how this works. So in our non-privatized healthcare system, there is actually a place in Ontario where you can purchase an MRI. How does that work?
Yeah, it's kind of, I spoke with a lady who's involved with that. It's not as simple as going to the US. You have to, it basically has to be your employer or a third party that pays for it. So if you're, Joe Worker and your employer's not going to pay for it, you can't go to one of those facilities and get it. And the other thing is they're actually done in government facilities. It's the government.
Or no, there's a privately owned facility. They run a series of clinics in the province that are geared towards diagnostic imaging. So they do bone scans, they do different types of cardiac scans, they do they do MRIs. Okay. So you can get the MRI if it is not an MRI that is regularly available to people, to patients. So say, for example, a breast MRI for a woman is significantly more sensitive and than a routine mammogram, and without the radiation. So here's a superior test, far superior. How do I get an MRI for a patient of mine that's got, if you've got a female patient that's got a very dense breast tissue, it's very difficult to read the mammogram. So if you have a patient that needs a breast MRI, you have to jump through hoops to get it. But they can call this clinic and get it and pay for it privately because it's not readily available as a part of an OHIP stream. See what I mean? So they can purchase that, but you can't say go and get your MRI of your knee and pay for that. No, you're right.
Yeah.
You have to,
Yeah, that's Ontario is one of we did a report on the growth of private MRI clinics in Canada from 1994 when the first one opened in Alberta to now, and it's now a majority of provinces where you can actually pull out your debit card, your credit card, whatever, and pay for an MRI scan.
right.
Instead of waiting for the public system. But to come back to what you were talking about with the aging population, what are your thoughts about that going forward? Are you quite concerned as a physician with this huge influx of society, the baby boom generation, which is now entering that stage where they're needing more expensive health procedures, and governments
Yeah.
haven't saved any money. They knew this was coming for decades. They didn't put aside a
Yep.
penny.
Nope.
What's your reaction to that?
Well, I mean, I'm obviously I'm scared shitless. It's not, I mean, as a physician and as an old person, I mean, I'm 63. I mean, I mean, pretty good health. I'm still golfing and I'm still, active, but, my husband died 5 years ago. He was 59. I'm painfully aware that things can change very quickly. And so, I'm very concerned about how things are going to look, the landscape, how people are going to, seniors are going to, what sort of resources are going to be available for them. Look at what's happened. I don't know about in Alberta, but it was like a really bad situation here with the pandemic in the nursing homes. Like, it was bad.
Yeah.
So and it really, really brought attention to and it spotlighted on the deplorable conditions. I mean, it's not a priority. Let's face it, it's not sexy. It's not brain surgery. Nobody cares about whether or not nursing homes are getting adequate funding and proper care, and that you can, I know for a fact that there are people who had their licenses taken away for criminal activity who have now opened up nursing homes again. So it's a business that tends to attract the unsavory. Let's just put it that way.
Wow. Well, that's certainly not good news if we're thinking about our futures and maybe having
No,
to rely on
no, it's just when I was a resident, I was actually toying with the idea of doing geriatrics because I was really kind of interested, but not so much interested in hospital geriatrics. Like, I don't care what your serum rhubarb level is. I really want to know, like, it's more community stuff. Like, how are we screening elderly people for driving? There's no consistency across the country. Every province has, I think in the Maritimes, one province, you just write in and get your license. Okay. So how about Alzheimer's? That might be something to screen for. So, I mean, I was looking at community-based geriatrics, and I, started to realize that it's just woefully inadequate, the amount of services, the amount of resources, the amount of stuff we know. There's just a lot of stuff we don't know about an aging population.
Yeah, I'm concerned about it on many of those fronts, the ones that you mentioned, but the financing aspect especially, and you look at the situation government's in right now financially with COVID and having to spend all kinds of money on other things. Many provincial governments were not in a sustainable track heading into COVID, right? In terms of what the expectations for support in healthcare versus what future revenues were going to be. There was already a mismatch there. So it's it's going to be even more difficult going forward. We've chatted about a lot about sort of different aspects of shortcomings related to the system. I don't want to just dwell on the negative. What do you think is the positive when you think of the sort of the bigger healthcare system in Canada? What are the aspects do you think, this part really does a good job?
I was thinking about that also. And I think that when I first started out 30 years ago, we were doing written charts, written records. We were doing, my booking was done on a computer, but billing was done on cards, believe it or not. There were these computer, I don't know if you ever remember doing those computer programs where you have to fill in the dots and then you put them in the machine. You have to, almost like a Fortran, but anyways, that's way back there. So billing was done on these cards, and if you made a mistake and put the penciled in a dot, then the whole thing got rejected. But so going back from the dark ages when we used to write on tablets to now, where you have an EMR system in your office, so all your records are done in the electronic medical record on the computer, and prescriptions. I mean, whether it's good or bad, I no longer write prescriptions. I just send them from the software right into the drugstore. I mean, when I'm on call, the odd time I call a drugstore and ask for a prescription, but I have like a box of 1,500 prescription pads that I probably will never use again. And I'm not sure if I'm ever going to remember how to write Latin and write a prescription, but there's no need for it because everything now it's all software, it's all computerized, it's all electronic. So how has that made things better? Sharing of information, speed. So, it's just a lot quicker. I still think that there's something, inherently primitive and almost integrative when you write. When I used to write my notes, it was almost as if they were embedded in a different way. And I find that now that I'm typing them, they're not sinking in. I won't remember the details of an encounter like I did when I wrote them. But generally speaking, I'd have to say that's a big plus. There are still some screw ups, like, probably what happens, this happened, where I live happens to be I'm not sure about the grid system, but our power goes out often and for no good reason. It's a perfectly sunny day. So if the power goes out in the office and your EMR doesn't work, we're running around like chickens with our heads cut off going, oh, I have to write a prescription. Oh, where's the prescription pad? I don't know how to do this. Like, and you think, wow, like we're losing these skills. You don't want to not, like, you have to, it's almost like keeping up with ancient tradition, like the anthropologist in me says, well, we can't forget how to write a prescription and we must still write the occasional note or letter. I feel like I want to start writing letters to my friends so that I can remember how to do cursive. But yeah, it has been a blessing, but I worry about relying on the technology too much. Certainly with the pandemic, the electronics have been handy because I have not been off the entire time. I've still gone in the office because, unlike some of my colleagues, the province still dictated that you had to see newborn babies, pregnant women, and children that needed vaccinations. So some less brave colleagues would delegate that to their nurse or nurse practitioner. But I feel like if you're going to have your staff in your office answering your phone and triaging patients and seeing them, then I think you should be there too. So I have been there the whole time, but not seeing very many people, but certainly getting stuff by email has been great. So, Joe Blow's got a weird looking mole on his butt, so he sends me a picture. I mean, if anybody ever looked at the emails I've gotten, it would look like the weirdest set of porn you've ever seen. There's all these weird body parts with strange lumps and bumps and hairy things. But yeah, so it's been a godsend to have the email contact. I don't have the like this. I don't do the Zoom things in the office. I just basically call people on the phone or I get them to send me emails. But once they lifted and they started relaxing, the stages, now I just see anybody for anything. Whoever wants an appointment can have it for whatever they want. You've got the plexiglass up, you've got the PPE, we're good. And we need to start getting back to doing things and showing people it's okay to get back to work and do what you need to do and be smart about it. And you're fine. We don't all need to go crazy and start getting hysterical because we're worried about getting COVID. I've got a mask, you've got a mask, we're all good.
Well, we certainly can't have a society where everyone's sitting on the sidelines and very little work is happening, right? You need the economy to keep going to power government and
well, there's a lot of people that are still thinking they're not moving off they were just waiting for that chance to be a couch potato, and now that they've got it, we are having a hard time getting those potatoes off the couch. They do not want to move. I think a lot of people are really, they complain about the lockdown, but I think a lot of people really like the option of being able to opt out of work and stay home,
Well,
not one of them.
The federal government has 70,000 plus employees who were given free time off, fully paid to do whatever they want during the lockdown. So I can understand certainly why some people may grow to quite appreciate the lockdown and
no kidding.
All this extra free time getting fully paid for it. But that's a whole other subject. I want to just close by asking, is there anything that we haven't touched on that you think is important to raise?
No, I think that one thing that we, might be helpful in terms of being able to bring, um, have it be more of a unified system is to look at trying to develop some standards across Canada for, approaches to aging and drug plans and that kind of thing.
Mhm.
And I really think that, it's like I said when I was talking to Heidi that it reminds me of when in the 70s, I remember it was unbelievable trying to find a place that was open on Sundays. There was this mindset that was just, you can't open on Sundays. It's a God's day and you can't open on Sundays. I mean, you're going to burn in hell if you go to, and then, so people just say, well, tough, I'm going to open Sundays and I'm going to take the fine. Come and give me the $5, the $5,000 fine. And then it was just unbelievable. And the thought of a liquor store being open on a Sunday. Are you kidding me? So now look at it. Everything's open Sundays. I mean, here was this sacred cow that we basically dismantled. And it's like people just kept chopping away going, yeah, but I work, 6 days a week. Sunday's my only day off. Or Sunday isn't my religious day. Let's look at other religions. I mean, for people who are in the Jewish faith, their day is Saturday. So why couldn't they have things open Sunday? So we started chopping away at it. Now everything is open Sunday. You can go to the movies and you can go to restaurants and you can go to stores. You can go to even banks. And I think it's the same thing. We're looking at healthcare and it's this sacred cow and it needs to be dismantled and people need to be able to purchase whatever. If there's access to private clinics or private healthcare, they need to be able to do that just like we can send our kids to private school. It's no different.
Yeah.
Right? If all the private schools closed under the same premise that we have to have universal education, like universal healthcare, the whole system would implode. It wouldn't even be able to hold all the kids. So now that's what we've got in our healthcare system. So let's open up clinics. Let's open up, surgeries. Let's do this. Let's give the people who have got the funds the ability to purchase what they need and leave that space open for the people that can't afford it, that have to rely on the publicly funded system. Absolutely. And this notion of, well, all doctors are evil. I mean, I got that when I was doing health policy in my Royal College thing when I was doing the community medicine fellowship. All doctors are evil. If you decrease the cost of a service, then the doctors will just double the amount of services that they do. It's like, oh yeah, I'm out there with a sign on the sidewalk saying pap smears 2 for 1. Come on in. Like. There's demand. There's public demand. Patients are coming to me. I'm not saying, come on in, everybody. There is definitely demand out there. So why shouldn't the demand get met? It's not like we're trying to be right. So anyway, this notion that doctors are evil, and so this is just a rhetoric that, if you open up the system and you allow people to pay, all the doctors are going to jump and say, oh, I'm just going to do private because I can charge more. And all the people in the publicly funded system will just be, left, in the wasteland. That's just nonsense. That's not sound at all. What we need is to give Canadians a choice that they are, like we do with education, so they can purchase what they need. And then we open up the system. It's a way of providing, a safety valve and making it possible to care for our elderly.
So you keep the public system, but then you also give people the choice. If you don't want to use
Exactly.
the public system to get your knee done.
Exactly.
Yeah. Yeah.
I mean, that's what we're talking about. That's what you mentioned at the very beginning is, choice. And what I'm finding more and more with this government is that, it pretends to be a government for the people, but I find it very oppressive and there isn't much choice. They're taking a lot of your choice away. There's more and more restriction, right? There's more, telling you what you can do and what you can say and where, this kind of thing I see it as a very oppressive regime in a way. And I think we need to open it up and it needs to be more open. It needs to be more free. People need to be able to access what they need in a timely manner so that we don't have horror stories. And I really don't think we know about half of them. I think there's a lot of people, mentally ill people with serious skin problems and people that need joints done that we're not hearing those stories because They just go by the wayside.
Yeah. And the thing that strikes me is that we're the only country on the planet that does it the way we do it, where we say to people, sure, you can go out, you could have McDonald's for every meal, after, you've chowed down on your Big Mac, you can follow it up with, a couple Ryan Cokes, and, maybe go by a safe injection site and take some heroin or whatever. The government's fully fine with people doing things to harm their bodies.
Yeah.
If you want to spend your own money to try and, get your knee done in a timely fashion, so you're not sitting on the sideline.
It's not wrecked, right?
You can't do that. Like, is that not absurd?
Oppressive? Is that not oppressive? Yes, yeah. I would say that that's the mark of an oppressive. What they're doing is people have been misled. People have been led to believe that if you take away this fundamental, this universal healthcare, this Tommy Douglas thing, that all of a sudden we're less Canadian, that we're no longer, this is it. Everything's going to implode. House of Cards, it's all going to come down. And that's complete nonsense. It's complete and utter nonsense. I see little things are creeping in now. You go into hospital. I had brain surgery some years ago. I had to have a nerve fixed. I was at the London University Hospital in London, Ontario. Fantastic surgeon. And afterwards, I've got to buy these stockings so that I don't get a blood clot. Well, there wasn't a lot, but it's still a fee. It's a charge. So not everything is free in the healthcare system. Yeah. And what if I couldn't afford to buy those stockings? It was no problem. But what if I couldn't afford to buy them and I didn't get them and I got a blood clot in my leg? Whose problem would that be? Because they didn't provide them for me, right? The government can pick and choose what it is and now physiotherapy in the province is delisted. No longer don't get physiotherapy covered in Ontario. I think there are some specific cases, like there's a few things for seniors maybe, but physiotherapy used to be all covered. It's not covered anymore. If you have a car accident, you get it covered through your insurance company. If it's a work accident, you get it covered through WSIB. But if you screw your shoulder up playing tennis or golf, you got to go and pay out of pocket. So there's lots of things that you have to pay for. You have to pay for a chiropractor, acupuncture, massage, physiotherapy. I don't know. They can decide what you have to pay for, but you can't go and get an MRI of your knee, or you can't go and see a surgeon and get your knee replacement done because you can afford to pay for it. I don't know.
There's a real gap, isn't there, between what people perceive about Canada's healthcare system in terms of what you talked about, the free notion, and also how we think of our system compared to the rest of the world. Like I think we got a lot of education that still needs to occur to just to inform people, get them thinking about some of these things. But I've very much enjoyed our conversation today.
Yes,
I'm glad you took a few minutes to share your thoughts about what you're seeing on the front lines. And I'm going to try and twist your arm again in the future at some point to come back. We'll have a chat about something else, because I think we could probably have many more of these discussions. It's been great. Thank you.
Oh gosh, I have a feeling. I'm not shy on opinions, so by all means, it's been a pleasure, and I welcome the invitation, and I look forward to talking to you again.
Great. Thank you very much, Doctor.
You're welcome.